Hello everyone, I'm Mei Yu, the nursing student of WSU. Today I'm going to give the presentation about an embolic stroke patient. The patient was in charge 2 days ago with the dizziness and palpitation, and she was confirmed with the atrial fibrillation. She's on telemetry and commenced on hyperinfusion, and she got a decreased levels consciousness, slurred speech, and left side weakness during the night shift. So she is on acute neural deteriorating, like cardioembolic in origin from the atrial fibrillation. Today, I'm going to do the A2E assessment on her and give the high priority nursing interventions and information about the medications. The patient's airway is patent and equal entry. So we need to position the patient semi to high followers section ready because the patient is still unconscious. The respiratory is 26 shallow. The saturation of oxygen is 95 on Hansen's max over 60 liters oxygen. We need to maintain the saturation of oxygen equal or over 95. And step down if the oxygen over 96 percentage, and increase the oxygen if the saturation lower than 94 percentage. Her heart rate is 136, which means atrial fibrillation with rapid ventricular response. And blood pressure is 180 and 98, which means hypertension. Her hypertension means to preserve the cerebral perfusion pressure. And capillary refill rate less than 3 seconds, beating edema in feet. Beating edema in feet means a venous congestion from the right side dysfunction, which is a sign of earlier heart failure. Her disability GCS score is 12, and left hemiparesis and facial droop, aphasia, pupil rounds equal and reacting briskly to light. We need to continue do the neural assessment on her because the acute ischemia of the right side cerebral hemisphere consistent with the embolic stroke. And her skin is febrile and skin intact, so we need to ongoing monitor. The first step, we need to active a cold stroke and prepare for the reperfusion. And we need to make sure the stroke team are notified and stroke nurse attends immediately. I record the last novel time at about 1 a.m. because every minute matters. And we need to arrange an urgent non-contrast CT and draw the baseline for the coagulant test and lab and troponin because the CT can exclude the intracranial hemorrhage and CT angiography, CT perfusion can help define the large vessel occlusion and salvageable tissue. We need to make sure IV is valid so that we can get ready for the IV thrombolytics on time. And the reliable IV cannula can prevent the treatment delayed. So for the preparation for perfusion, we need to make sure as fast and safety as possible. We need to do the airway aspiration management and oxygen titration. We position the patient semi to high flowers around 45 to 90 degrees to help the diaphragm move relay and promote the chest expansion, improving ventilation. The patient is kept nearby mouth, so until a swallow screen confirms the safety, it can prevent aspiration and reducing pneumonia. If her GCS drops by 2 or more than 2 points, or the airway becomes compromised, we need to immediately call a MET or rapid response. Oxygen, we need to maintain a suitable oxygen level. If the saturation of oxygen lower than 94, we need to increase the oxygen. If the over 96, we need to step down to 1 to 2 liters. Because the maintaining optimal oxygen levels can prevent hypoxic injury and avoiding hyperoxia. We need to monitor the circulation to meet the blood pressure target and monitor the atrial fibrillation rhythm, the rate. We do the continuous blood pressure and ECG monitoring to check both perfusion and rhythm. Blood pressure is maintained below 185 and 110 before IV thrombolytics and below 180 and 105 for the next 24 hours to support cerebral perfusion without increasing the bleeding risk. If the patient has atrial fibrillation with the rapid ventricular response, we can give the treated hemodynamically safe therapies such as beta blockers. And the rationale is that mild hypertension improves the cerebral blood flow, but excessive blood pressure raises the risk of hemorrhage. And the rate monitor can detect the tachyarrhythmias and instability early, ensuring timely intervention. We need to do the neural assessments and prevention. We watch for the GCS closely. If the patient only open eyes to voice, we need to call a clinical review for possible deterioration. And neural ops, we do it frequently every 15 to 30 minutes. It can help the early signs of perfusion failure, edema, or bleeding. And we need to protect the left weak limb with the supported with the pillows. And do this left limb protection, it can help preventing subluxation and pressure injury, edema, and improves the patient's comfort. IV Outblaze, also known as RTPA, the key thrombolytic drug for ischemic stroke. It works by converting the plasminogen to plasmin, which dissolves the fiber clots and restores the blood flow. Before the administration, we must confirm eligibility, and the non-contrast CT must show there is no intracranial hemorrhage, and the last novel time must be within 4.5 hours. We also check platelets, INR, APTT, and renal function. Because this patient is already on a heparin infusion for atrial fibrillation, so the heparin must be stopped and a normal APTT confirmed before giving RTPA to prevent bleeding. The dose is 0.9 milligrams per kilograms and a maximum 90 milligrams within 4.5 hours. So for this patient, we need to give the 10% IV bolus over 1 minute, and then for the rest, 90% IV infusion over 60 minutes via pump. And we need to use the infusion pump clearly label thrombolysis in progress. For the other antithrombotic, we need to withhold for 24 hours. And we need to maintain during and after infusion, we need to closely monitor for intracranial or the systematic bleeding. Check vital signs every 15 minutes during infusion, and then every 30 minutes for 6 hours, and hourly up to 24 hours. Maintain blood pressure below 185 and 110, and monitor heart rhythm, temperature, and keep the blood sugar within 4 and 10. So the RTPA is a time critical, high risk, but potentially life-saving when we delivered safely. Metoprolol 50 milligrams twice a day. It is a beta blocker, so it is used to lower down the blood pressure and heart rate, make it easier for the heart to pump blood to the rest of the body. In this case, the patient has atrial fibrillation with rapid ventricular response. Her heart rate is 136 and blood pressure is 180, 98. The goal is to slow down the heart rate and avoiding a rapid blood pressure drop of more than 15% to stay within the safe thrombolysis parameters. Before giving metoprolol, we must check a baseline ECG and withhold the dose if the heart rate lower than 60, or the systolic blood pressure lower than 100, AV block, or acute heart failure is presented. The patient remains near the mouth until the swallow screen confirms the safety. Drug interactions are important. Verapamil, diltiazem, digoxin, and amiodarone can increase the risk of bradycardic or AV block, while enzymes can reduce the antihypertensive effects and increase cardiac risks as well. During therapy, we need to monitor for hypotension, heart failure worsening, such as the dyspnea, crackles, or edema, and the bronchospasm. If visiting or oxygen, the saturation of oxygen drops, stop the drugs and give a bronchodilators. We also assess the peripheral perfusion and check heart rate and blood pressure before and after each dose, maintaining heart rate between 60 to 100 beats per minute on telemetry. Metoprolol stabilizes the rhythm and the rate control safely only when we treat the heart carefully. Pantoprazole 40 milligrams daily. It is a proton pump inhibitor to reduce the gastric acid secretion. In stroke patients receiving anticoagulants or thrombolytic therapies, the pantoprazole helps protect the gastrointestinal tract and to prevent upper GI bleeding. Pantoprazole provides gastric protection and supports safety of the anticoagulant therapy during stroke management. Before starting, we assess for abdominal pain like nausea, vomiting, as this may indicate pre-existing GI injury. For administration, the usual dose is 40 milligrams once a day, either orally or intravenously. If oral, it should be given before breakfast on an empty stomach to maximize absorption. If IV, we dilute according to the hospital protocol, administer slowly over 2 to 5 minutes via the dedicated line to avoid irritation. Pantoprazole is generally well tolerated, but mild side effects including the headache, nausea, or diarrhea. Serious but rare effects including low magnesium, C. difficile infection, or skin rash with long-term use. We must monitor for signs of GI bleeding such as black stools, vomiting blood, or hemodynamic instability. If vomiting occurs, assess for aspiration risk and remain alert for signs of infection. And that's my presentation.